Oral cancer screening devices. Introduction. Our group decided to choose oral cancer screening devices to use for our EIDM checkpoint assignment and whether they actually improve early detection compared to traditional methods. Oral cancer is one of the most common cancers, and early detection is crucial when it comes to improving survival rates and implementing care before the situation becomes serious. However, this is often not the case due to lack of detection screening devices, lack of symptoms, and lack of awareness. Recently, new screening devices like Velscope have been introduced into the dental scope of practice to help improve early detection of lesions or oral cancer symptoms. This is what raises the question of how effective these devices truly are. For step number 1 of the EIDM process, we asked a focused clinical question using the PICO format. Our group created the question, in adults attending regular dental care, does the use of oral cancer screening devices or adjuncts improve the early detection of oral cancer and precancerous lesions compared to visual and manual examination alone? This population includes adults who attend regular dental visits. The intervention is the use of oral cancer screening devices or adjuncts during an examination. The comparison is the standard visual and manual oral cancer screening performed. The desired outcome is to determine whether these adjunctive tools enhance the early detection of oral cancer and precancerous lesions.
Collecting data. To collect reliable evidence, we used databases like PubMed and Medline and used keywords like oral cancer screening and early detection devices. We used Boolean operators to narrow our results and focus our high-quality studies like randomized controlled studies and cohort studies to reduce bias. In addition to that, we also had a hard time finding some of the articles without having to pay a fee, so we were able to find them for free using Google Scholar. The articles. The first article that we reviewed was on Toluidine blue. The first article we looked at was on Toluidine blue being a screening adjacent method. It showed a slightly higher detection for premalignant lesions, but was not very reliable. The study was strong because it was a randomized controlled trial, but it had limitations like a short follow-up period and only included high-risk individuals, which created bias to the study. For the article we found on Velscope, our second article, this showed a higher sensitivity, which made it better for early detection. However, it produced a very high chance of false positives. This could lead to unnecessary biopsies, which is a huge problem. The study also had a small sample size, which affects reliability. Also, including that to use a Velscope, you needed professional training, so it doesn't make it as reliable for the everyday clinician to use. So, were they useful? The articles we reviewed help us understand oral cancer screenings and the use of different devices. Sources we looked into like Jones, Mayo Clinic, as well as the two articles we spent our time researching, explain the importance of routine visual and manual exams. And Lima showed how delayed diagnosis can worsen outcomes. So using as much as we can to detect cancerous lesions is essential. However, the articles were more general and not strongly evidence-based. The studies we saw seem to have many limitations like small sample sizes or short follow-up periods, making it harder to fully rely on their results. These limitations make it harder to fully trust the results or apply them to all clients in care, especially when they don't have a broad population they're testing. So while the articles were helpful and gave insight on some oral cancer screening device aids, they did not completely or strongly have conclusive evidence to fully answer our PICO question. Statistical significance. After reviewing the selective articles, the results were not consistently statistically significant. In the study using Toluidine blue, there showed a slight increase in detection of oral premalignant lesions and a higher detection of oral submucosous fibrosis. However, the overall results were not statistically significant, including the reduction in oral cancer incidence after follow-up. This means the findings could have been due to chance and do not strongly support the routine use of this adjacent. In the study using the Valscope, it showed a large increase in findings, but also in false positives. But the study did not clearly report statistical significance for these findings. Additionally, the small sample size makes it difficult to determine if the results are truly reliable. Although both studies show some positive trends, the lack of strong statistical significance to add to the use of these devices in a daily setting. This means that more research is needed before these devices can be confidently used. Let's put this in a clinical scenario. We have a client who's 52 years old. He smokes daily and drinks alcohol regularly. He comes routinely for dental cleanings. He has no pain but a small white lesion on the lateral side of his tongue. He's concerned about oral cancer after seeing info about it online and info about screening devices. So, would either of these two devices in our article truly be helpful to this client? Let's take a look at our worksheet to figure it out. Are the groups similar enough to apply to my patient? Well, yes. The study focuses on high-risk individuals who get regular dental services, which our client does. Is this available, affordable, and appropriate for the patient in the setting? Not really. It depends on the practice, but the Valscope is expensive and it needs specialized training, as well as Toluidine Blue is not very commonly seen in practices, so the odds of these actually being in a clinic are low. Will this help the patient meet his or her goals or address their chief complaint? Definitely. The client is concerned about lesions that may be cancerous and asking about devices that may aid in detection, so using these definitely wouldn't hurt. Is the difference large enough to warrant the treatment? Not really. Not strongly, as the Valscope has many positives and Toluidine Blue has not been proven very effective. With all of the false positives of the Valscope and the lack of effectiveness of the Toluidine Blue, there really may be a small reason to use these. Adverse effects, yes. Very high false positives for the Valscope and unneeded biopsies. None for Toluidine Blue, but we wouldn't want to get our clients' hopes up or have them assume certain things could mean they have cancer. It's really important to talk about the risks and the benefits of using any kind of devices and adjacents with the client before their use. So, what else could be a reason to use this or not for our client? Summary of evidence. Both agents show an increase in premalignant lesions. Valscope has more self-positives as Toluidine Blue, as mentioned. Toluidine Blue shows only a slight improvement, but not statistical significance, and neither show strong evidence to reduce oral cancer indices or long-term outcomes. The summary? Well, visual and manual oral cancer screenings are still the standard care of need, and these aids may be helpful in high-risk population only. As we saw in our articles, they were mainly used on people who already had a high chance of having oral cancer. So on our day-to-day clients, it may not be as helpful. And you have to have proper training to use either of these, which a lot of clinicians may not have. The patient preferences and values? Well, the client wants an oral cancer screening done, and they want the detection for reassurance. They may be interested in trying different devices to confirm it, and you need to explain the limitations and expectations of using these aids. The summary of the client and patient circumstances: high risk, smokes and drinks with a potential cancerous lesion, so they fall under the scope for the articles. Proper and in-depth screening is very important to detect, but we need to balance detection and unnecessary procedures. So we don't want to use that Valscope and need an unneeded biopsy. Our overall recommendation for our client would be based on their findings and based on our findings with the Valscope and the Toluidine Blue. They can be used as adjunctions. They should not be used on their own. They should be used with regular visual and manual oral cancer screening standards, especially in high-risk or low-risk clients. However, due to the low statistical significance and the small sample sizes and high false positives, These tools cannot replace the gold standard cancer screenings. They should be used with clinical judgment and specialized training. So, our client may benefit from the use of these, but we have to make sure they understand what these tools do, and as a clinician, we understand how to use them.
Research, reflection, hypothesis, and statement. We believe that one major gap in our research is the lack of a study with a variety of participants. Since the studies included focusing on small sample sizes with individuals who are already at high risk, it sets us back as it isn't as reliable as longer-term study with randomized clients would. The hypothesis. Clients who complete oral cancer screenings with smart and advanced technology and/or devices such as Velscope will have a higher rate of early detection in cancerous lesions in the oral cavity. Statement. The purpose of this oral cancer screening device study is to determine the effectiveness while using oral cancer screening devices like Velscope to aid in the improvement of detecting early cancerous lesions within the oral cavity when compared to the use of standard examinations over a long-term period. Proposed methods. Sample. A randomized and diverse population in a controlled trial of clients who attend regular dental appointments, not only the high-risk clients. Study. Group 1 will include the completion of a visual exam, while Group 2 will include the use of oral cancer screening devices such as Velscope. Timeline. Long-term follow-up maybe a year later to see if there were real outcomes to the study. Outcome. The outcome should be that there is an increase of early detection in oral cancerous lesions. Statistical analysis. Using a statistical analysis will make sure that everything is documented accordingly to determine the outcome of the study. Conclusion. Oral cancer screening devices show an improvement for the detection of cancerous lesions in the earlier stages, though there are some barriers to overcome, such as the sample sizes and timeline for these two studies, and more research regarding these tools is necessary. Overall, visual examinations and screenings are still crucial in the dental hygiene world, and assessments as this technology is still under the works. We hope you learned something. Thank you for listening, and we hope that you get a chance to try these in the future and that the dental work will continue to develop new ways to find cancer and save lives.